rolling. It is bright and early on Tuesday. People are getting ready to apply to med school. People are getting ready to take the MCAT. People are getting ready for all sorts of stuff. Let's go ahead and do this real quick. All right, guys, welcome in. If you are new here, my name is Dr. Matt, and I am one of the most experienced MCAT tutors and med school admissions coaches in the country. If you have a question about getting into med school or about the MCAT, drop it here. We are likely only going to be on about 15 minutes today, so get those questions in. Ask your questions here about the MCAT and getting into medical school. Alrighty. Let me drop the same message over here. Ask your MCAT or Premed questions here. There we go. Welcome in, guys. If you are new here, if you're thinking of becoming a doctor, let me know what your questions are. So let's see. Last time we were going through our list of steps on the journey to becoming a doctor. I think we should keep on going. Let's see. Where was our... Yeah, stages of becoming a doctor. Step 1 was thinking about it. Step 2 is trying... Let's see. Let's call it volunteering. Let's see. Seeing what it's like. Right? This is our volunteering in a clinic or hospital. I'll save that there. All right. Perfect. Here we go. All right. So last time we started talking about becoming a doctor. Step 1, thinking about it. Today we're talking about step 2, seeing what it's like. If you are thinking of becoming a doctor, the next thing you need to do after thinking about it is to actually see what it's like. So this could be shadowing a doctor in a clinic. This could be shadowing a doctor in an urgent care facility, in an emergency room, or in a hospital or an OR, somewhere where doctors work. You need to have an idea of what it's actually like to be in a doctor's office or practice or OR, as long as you are there with a doctor, seeing what a doctor does and get an idea of what it's like to be a doctor. Before you set out on the very, very long journey of becoming a doctor, you need to see if this is for you. All right, guys, welcome in. Welcome. So we've been talking about the steps to become, we got a non-traditional in the house. Fortress says starting medical at 36. Way to go. I will be rooting all the way. I graduated med school just shy of 40 years old, and it is awesome to do med school in your 30s. And it's awesome to be, getting taught by a bunch of people who know way more than you and are younger than you. Highly recommend it. It's awesome. And you can always, approach each day and each experience in the hospital with the chill vibes of having already lived way more life as a grown-up than anybody else around you. I have literally been in countless surgeries and ORs and trauma bays and emergency rooms and patient encounters and all kinds of things with instructors and attendings and residents who are more trained and yet nonetheless are younger. And I think it's awesome. It's especially awesome and funny when you have people on the medical journey who are like really, really young and don't have, didn't have any career or job or anything, and got out of high school when they were young, and then got out of college when they were young, got into med school when they were young, and you're there in your 30s figuring out how to become a doctor right next to somebody who is nearly half your age. It's awesome. But the funny thing is, you think that you are, the senior citizen on the ER floor in the hospital ward until your other classmate walks in and they're 55 years old and they're starting medical school too. And then you realize that somebody else is twice your age and they're just now starting. So it's never too late to start. I don't think it's ever too late to start. So welcome in, guys. If you're non-traditional, that's awesome. If you're not a non-traditional, if you're traditional and you're on your way to becoming a doctor and you're in your 20s, that is awesome as well. Drop those questions here. I will let you guys know we are probably only going to be on about 9 more minutes. This is going to be a pretty short little 15-minute live. If you have questions, drop them here. If you are on the journey and you need help, do not forget that, and I should flip this screen over. Which screen is this one? I should flip it to this one. Do not forget that there we go. I think I fixed it. Do not forget to drop a message at mcatboss.com if you need help figuring out how to study for the MCAT. User says specialty. So I am a MD with distinction in research, and I work on neurodegenerative disease. So I am part of a group that is trying to bring the world the very first cure for Alzheimer's disease and potentially Parkinson's and a number of other dementia-related diseases. So that is my passion, and my other passion is getting the next generation of people into med school. So I have been a amyloid beta. Yes. See now the question there is, when you hear amyloid beta, do you think neurotoxin or do you think really good, really important thing? Because the old way of thinking about this was to essentially paint it as a neurotoxin, and it turns out that that is a mistake. Amyloid beta is not a neurotoxin at all. It, in fact, is a functional neuropeptide. That is a sort of a huge error in the field, that they used to assume / treat it as though it were a neurotoxic thing, and it is not. So very cool. Welcome in. If you guys are new here, so we're going to totally take the neurodegenerative disease pivot here, since there's not a med school admissions question on the board. Thank you for the comment. So the general explanation that was given in I'll give you the Cliff Notes history of the theory of Alzheimer's disease. Started in 1906, 1907 with Dr. Alzheimer, who had a patient who died, and they did a slice and stain of brain tissue and found plaques. And these are sort of the classic amyloid beta plaques. And they didn't actually propose it to be neurotoxic all the way back in the early 1900s, but in the 90s, they proposed that there was this somehow either an overproduction of amyloid beta, or that there was indeed a problem with clearing enough of the amyloid beta, and they thought it was instead plaquing up the brain and causing neurotoxicity. Good morning, Gus. Welcome in. And it turns out that this hypothetical amyloid toxicity, thanks for whacking that like button, guys. Drop those questions in, comments in. We're only going to be on a few more minutes, having a little awesome, fun side conversation here about the dying old theory of Alzheimer's disease as a disease of excess amyloid beta. It turns out that was a mistake, and it turns out that amyloid beta is actually a functional neuropeptide that has been protected in evolutionary biology for about 400 million years. If you have a brain and a backbone, you probably have amyloid beta, and it is the way that your hippocampus actually undergoes the long-term neuronal potentiation and forms memories. And you can't really form memories if you don't have enough amyloid beta 42. So it's our particular startup is working to correct that misunderstanding. Cretan says, my MCAT score drops today. I'm terrified. You got this. It is a nerve-wracking day when your MCAT score comes out. I understand. At Time says, isn't Alzheimer's a break in the blood-brain barrier caused by decrease in hormone production? I have not heard that particular proposal. people who have Alzheimer's do still have a blood-brain barrier. There is some degree of neuropeptide transmission across the CSF, but they do still have a blood-brain barrier. Gus says, how should I highlight my research in med school applications? So the people kind of take a little bit of a different approach, especially depending on whether they're either applying MD PhD or if they're bringing in a PhD and applying to an MD, where you have that very sort of deep research experience. If you have more of sort of like volunteering in a wet lab to fill some petri dishes thing, you really kind of have to mainly focus on the aspects of teamwork and laboratory function and all of that stuff. And it's not a lot about the sort of scientist's role in hypothesis formation, generation, and testing. When you do have the more advanced research, you get to actually highlight that, and that is a blast to do. Tier T, especially amongst possibly theorized to be a protected protocol. So there's a lot. So the comment regarding the sort of feedback loop with the like neuroendocrine feedback loop is a really, really, really complicated topic in Alzheimer's, because of the fact that both the disease frequency in males and females is very different. The age of onset is not exactly the same. And because when you break the treatment cohorts in Alzheimer's studies down between men and women, the same treatment that might be slightly relieving for a male patient has a way lower chance of helping a female patient. And this is, unfortunately, this is something that is not super well studied, because not enough studies actually break cohorts apart between male and female cohorts. So that there's certainly some sort of sex differentiated response to treatment there. Gus says, thoughts on PDGF beta in Alzheimer's. Oh, we're getting into the weeds. The primary bottleneck that is important as a predictive biomarker most likely can be both affected by multiple upstream factors and most likely can be an effector of multiple downstream effectors. And so the best example that I can give people is if you know anything about type 1 diabetes, type 1 diabetics do not produce enough insulin because of their pancreatic islet cells. And so if you can picture this sort of tree of possible factors that could drive damage or injury to the pancreatic islet cells, let's say there's 8 different causes, but they damage the pancreatic islet cells, and that one cause, that one bottleneck in the pathophysiology can then, because you don't have insulin, cause a whole bunch of side effects. And so multiple things can cause a bottleneck in pathophysiology that can cause multiple side effects downstream. And the complication with Alzheimer's is that we think that there's likely essentially a bottleneck like this, where there's a peptide that is decreased. It's amyloid beta 42 in the brain, functional neuropeptide that has to be present for memory formation and hippocampal activity. And even though it probably has multiple causes and multiple downstream side effects, that bottleneck we think is treatable. So thank you guys for helping me hit 1,000 likes. Appreciate it. Sorry for the side tangent there. For those of you who do not know, I'm Dr. Matt. I have been teaching the MCAT for a very long time, was close to 100th percentile scorer myself, and have worked for a bunch of MCAT companies. And I also am an MD who works in neurodegenerative disease research. So every now and then people kind of pull me into the side conversation on Alzheimer's, which is a very fun and tragic and interesting topic. Gus says, I'm investigating the role of extracellular signals in the role of epithelial fibroblasts. Cool. That is exciting. Very cool. It'd be super fun to read your doctoral dissertation. That is really awesome. At times says I'm an RN. Very cool. Pokemon says, isn't the beta plaque that's the main cause though? So it actually, Pokemon, thank you for the comment. It is actually not the amyloid beta plaque. That is kind of the old, that is essentially, in a nutshell, the very Cliff Notes version of the old version of the pathology theory for the toxic amyloid plaque theory in Alzheimer's. And it turns out that is apparently not not actually the cause. And there's a couple of ways that we know this. One is that tons and tons of elderly people have plaques, all the way right up into the 95th percentile high plaque load, and have absolutely no dementia. The other part is you can have dementia with absolutely no plaques. And then the third line of evidence is that you can have plaques and dementia, and even after 70% of patients on the anti-plaque drugs lose the plaques, they keep having the dementia. So the plaques appear to actually be relatively benign, possibly even beneficial to some people. I'm excited to share my research, my application. Aim 1 is looking at the role of extracellular vesicles and soluble factors. Aim 2 is using primary cells to model human susceptibility. Aim 3 is applying real-world exposures using transepithelial exposure model culture. Super, super cool. Very cool. Very, very, very cool. Is there a, Gus, is there a, I'm very curious to know, is there a particular, like, is the epithelial fibroblast communication signals that you're setting, are these related primarily to like normal physiology, or are these related to like the way that like a glioblastoma undergoes metastasis? Like I'm curious if you have a particular sort of pathophys in mind there. That's super cool. Pokemon says, is it, so it's not an isolated cause? Why is it so foundational until so long? That's crazy. I'm going to do research on bladder cancer, so this is all fun. Very cool. Bladder cancer is something I do not know a whole lot about. We, they teach us clinically that, if it's an older guy with urine in the bloodstream, then you assume it's bladder cancer until proven otherwise. Other than that, I don't know a whole heck of a lot about it. That is very interesting. And the question about Alzheimer's being an isolated cause, the answer is... there's very, very likely, in the same way that there is very likely multiple different reasons why a person could have pancreatic islet cell failure leading to type 1 diabetes, leading to hypoinsulinemia. The same thing is probably true for the A beta 42 drop off in Alzheimer's. Guys, thank you so much for the participation. I do hate to run so quickly. I'm studying pulmonary fibrosis in response to environment and inhalation toxins. Okay, very cool. You will really enjoy in med school if you get to do a rotation called advanced lung disease. The ALD clinics are fascinating for that. Ken says, I fell asleep during car section. How do I fix this? Ken, drop me a question at mkitboss.com. I am the best cars tutor in America. I am super serious about this. I have students all across America and in Europe as well, and I am very good at cars. I had 100th percentile score on that, and I teach the goodness out of that section. I am really good at it. If you want help, drop me a line. Stay awake. It's interesting stuff, but you probably need to practice a few different things. You got in C, awesome, dude. That's awesome. I have a few students who basically told me they were only ever willing to work on science and didn't want to work on cars. But that's hilarious. That's awesome, man. Congrats. Gus says, I've always wondered what about neuroinflammation, especially through fracture pathways. Oh yeah, there is. How 100%? Yeah, it is a super. Once you get to know the section and the test writers tricks, it is actually a gamifiably easy section. Like piece of cake. Finish it with 10 or 20 minutes left. It's super fun. Guess says, I've always wondered about neuroinflammation, especially factor pathways. Yeah, there are a few labs right now that are working on doing inhalation medications for Alzheimer's. It's really interesting stuff because you can essentially inhibit's the wrong word. You can blunt some of the olfactory pathways. You can blunt some of the neuroinflammatory signatures that are associated. Yeah, awesome. Oh, are you? Okay, very cool. Awesome, guys. Nice. That's awesome. All right, guys, I do have to buzz. I'm so sorry. Thank you for the participation. Thank you guys for the questions and the comments. And don't forget to drop